Hello everyone, in today's video the special guest is Dr. Rachel Brown, the author of the book Metabolic Madness, who will be discussing why diet could be the most important thing you ever do to improve your mental health. From ketogenic to carnivore, we'll explore the science behind these nutritional approaches and their profound effect on mental health. Enjoy! Hello Rachel, nice to meet you.
Hi, lovely to meet you. Thanks for having me.
Could you tell us something more about yourself? From what I know, you specialize in root cause psychiatry / metabolic psychiatry. How did you become interested in this field?
Oh, yeah. I've been working in mainstream psychiatry for about 20 years at this point in time, but I've had my own health journey over the years, and that's primarily where my interest came from in relation to nutrition. I've been in the low carb world for pretty much the same length of time that I've been working within psychiatry, although I was in and out of it a bit over the years. And latterly, not the last 8-9 years or so, I always lose track of time. I've been following a ketogenic diet myself, and then latterly carnivore in the last 5 years. But I've always had an interest in holistic health, despite having trained in allopathic medicine. And I guess a frustration of mine is just that there are limitations to some of the standard treatments that we use within mainstream psychiatry. And just combined with my interest in trying to find the underlying root cause and really wanting to understand why it is people experience symptoms of mental ill health, that's really led me to where I am today. Sorry, I got a frog in my throat.
No worries. So, do you have many patients struggling with protracted withdrawal, after quitting antidepressants or antipsychotics?
Yes, I've definitely seen people struggling, particularly if they stop medications too quickly or suddenly, as often tends to be the case. So within mainstream work, I often see people having to be admitted to hospital if they've stopped their medications suddenly. And I think, well, it's been really interesting with the publication of the Maudsley deprescribing guidelines in the UK. And I think there's a lot more awareness now about the withdrawal syndrome that can come with psychiatric medications. So I suppose what I'm saying is I think over the years, in terms of mainstream psychiatry, I've always been under the impression, and people talk about people having had relapses after they stopped their medications. But now, with more up-to-date knowledge, I know that a lot of the time that's actually part of a withdrawal syndrome.
Yeah, when they have they start having protracted withdrawal, they go back to the doctors and they're being restated the drug, and the vicious circles go on. So
Yeah.
it's good that you are aware of that and trying to help them, to come off the medication. So could you tell me what kind of support or interventions do you offer to help them navigate this challenging state, like regarding ketosis, regarding your approach to
Yeah, so primarily I take a metabolic approach within my mainstream work. So I've managed to start a metabolic psychiatry clinic within the NHS, which is really very exciting. I've seen some amazing turnarounds and results there for patients with diagnoses of severe mental illness. I suppose in my private work, I use that approach as well as additional approaches such as along the lines of circadian and quantum biology and also functional medicine. So sometimes people have more in-depth testing if we need to check if there are particular environmental toxins that are causing an issue underlying.
And
But
what tests are you running? Like, what do you advise them to check for those issues?
it depends on the situation, but an organic acids test, for example, can be helpful to have mitochondrial markers and an indication of what might be going on in the upper GI tract. For some people, we do microbiome testing. That's probably not my first port of call, but sometimes it can be enlightening. And then latterly, I've been going down the route of mycotoxin testing for a fair few people. I don't know if it's just the people who I've been seeing recently, or if it's partly because of my own health experience, because I know about mycotoxins, having had my own issues with them. But certainly very recently, everyone that we've done testing on has come up positive for mycotoxins, which might explain some of the underlying pathology.
And do you think it correlates with protracted withdrawal, or is like the underlying condition, or it's not related? Because it's hard to distinguish if it's related to iatrogenic injury from the meds, or is it something else?
Oh, it's very hard to say, I think, because the majority of people that I see aren't necessarily going through protracted withdrawal. A lot of them have either managed to come off medications previously, or they're on a cocktail of different psychiatric medications, but still symptomatic or struggling with side effects. And I don't have an awareness of any particular research showing in-depth testing and like along functional medicine lines of a sort of client group who's also going through protracted withdrawal. But from a theoretical point of view, I think if somebody is trying to come off medications and they do have underlying like heavy metal toxicities or mycotoxin issues, and it will make that process harder, would be my take on it.
Yeah, so it's on top of protracted withdrawal, those issues, and if they gonna be resolved, it may be easier for them to resolve the protracted withdrawal and recover from this. And okay, that makes sense, because I also have this approach that we need to take care of our bodies holistically, and it's much quicker to recover, because I work with people with protracted withdrawal as well.
Okay.
And I believe there is no other way to approach this besides, you can go back to meds or experiment with your body, but it's a risky territory. So holistic approach is, in my perspective, the only way to go. And I also read that insulin resistance gives give you a leaky blood-brain barrier. Could you tell us more about this, because it drew my attention, because it's quite important regarding the brain. So I was wondering.
Yeah, so it's also having high blood glucose levels as well that can interact with the blood-brain barrier and cause it to be more permeable. But certainly there's some clear research from Dr. Cynthia Culkin and colleagues in Canada, I think they're based, showing that within a cohort of people with severe and enduring mental health diagnoses, these people were symptomatic and no longer responding to standard treatment protocols. And all of the ones that on testing were shown to have brain insulin resistance, or insulin resistance more generally in the body, I should say. They also did scanning, and they showed that those people also had a leaky blood-brain barrier. And when they were able to reverse the insulin resistance, the leaky blood-brain barrier also improved, so the permeability of the blood-brain barrier. And I know, just from other knowledge in terms of environmental toxins, they can be an issue for the blood-brain barrier, and then gut health comes into it as well, because there's communication between the gut and the brain. And so, yeah, it's quite interesting once you start to tie all the underlying possibilities together.
Yeah, I mean, it's all connected, but do you think that antidepressants or psychiatric medications also play a role in this, like making blood barrier leaky, or is it just insulin resistance here?
Well, potentially they could play a role, because antipsychotics often induce insulin resistance. It tends to be more the modern antipsychotics, the atypical ones, but as far as I can make out, it can also happen with older style medications. And then there is some evidence to suggest that antidepressants longer term and at higher doses also increase the risk of diabetes.
Oh, sure. I hoped for that. I had some sort of insulin resistance / diabetes, and I assume it was related to sertraline intake. So
yes, it can be. And antidepressants, there aren't very many studies, but there's one older style study that shows antidepressants can induce food cravings as well. So I found that personally very interesting, because that's another area of interest of mine. But yeah, it's difficult.
Craving is related to this submania state. Do you mean like that their mood is highly elevated and people are like disinhibited, or is something else underlying this food cravings regarding antidepressants?
Sorry, what do you mean?
Because sometimes patients, like when they are on antidepressants, their mood is highly elevated. They have mania state or submania state, and they are disinhibited, like they don't control their impulses. So do you mean that the food cravings are related to this state particularly, or is something?
No. Oh no, just generally. So for anyone, so I'm not a great one for figures, but I think it was around about 30% of people, or it could have been slightly less than that, met full criteria for food addiction in some of the studies. But when they actually did the surveys and counted up number of food addiction symptoms, about 70% of the sample had around three of those food addiction criteria symptoms. So there's a bit of a spectrum of experience, but no, it's not related to antidepressants inducing a manic state, although obviously people can become disinhibited and change their behavior during those states, but it's more just generally.
Yeah, it's all related, but there is also a correlation between inflammation and antidepressants use or psychiatric medications use and protracted withdrawal. And what do you think about how inflammation correlate with protracted withdrawal? And do you have any, I don't know, guesses what might be the reason why protracted withdrawal triggers inflammation? Because it's also interesting topic.
Oh gosh, yeah. I mean, I don't consider myself an expert in terms of protracted withdrawal.
Nobody is. No, there is.
Yeah.
Like, the research is still going on. Nobody knows, but
Yeah,
you know, just it's just a talk. You know.
Well, I mean, I often, gosh, my view on health has changed a lot over the last 20 odd years working as a doctor. So I was trained very much to group symptoms together and make a diagnosis and then prescribe medications. And in the sort of last 4 or 5 years, with just further reading and study that I've done and training, I now tend to view more from a terrain theory perspective, so about the health of the body overall and optimizing specifically mitochondrial health. And I don't know how granular we want to get, because I know some people just aren't really into all that science, but I think mitochondria are fascinating, and really all long-term health outcomes are, you know, you can't really I can't think of a single health outcome really that doesn't have something to do with how our mitochondria are functioning.
Yeah, I was aiming this like to stimulate mitochondria to increase brain-derived neurotropic factor. So this is like, because to repair something that's broken, like, and you have the only tools you have is like healthy lifestyle basically, and you know the people forget about this approach to just take care of your body, not just popping a pill to ease the pain, but yeah, and. So, by the way, why did you leave the mainstream psychiatry? What was the drive? Like, what happened?
So I haven't left actually. So I'm still working within mainstream, but trying to focus more on metabolic approaches for people. Although I do have to prescribe drugs in certain situations. But to be honest, I've seen better results using metabolic approaches with patients or clients than in the last few years than I've ever seen in a 20-year career so far in mainstream psychiatry. So it's something that really sticks with you. Like I had 1 week not that long ago when 2 separate people said exactly the same thing to me in clinic, and this was a metabolic clinic, and both of them said, "Thank you, this has changed my life." And they don't know each other. It wasn't prompted, and I've just never heard words like that from anyone else really, in terms of all the other tools at my disposal within mainstream psychiatry.
And what particularly has changed their lives?
Using a ketogenic diet to manage their symptoms.
Okay, so basically you see that those metabolic approach has better results than prescribing medications, because
yes.
Okay.
Yeah.
But I assume that at first, when your patients are being prescribed antidepressant, they're for short term they are happy and maybe mood is elevated, but then they are crashing down and it's like not so funny anymore. But with ketogenic, it's more. I believe it's more stable and it does resolve those underlying.
Yes, it can absolutely.
Yeah, and did you have like patients in this protracted withdrawal or just iatrogenic brain injury caused like by psychiatric medications that you advise them to go into keto? And did you have any results in this specifically?
Gosh, that's interesting. So there's one particular person very recently, so in the last 6 months, that I've seen who experienced akathisia after stopping an antipsychotic, and they hadn't been on the antipsychotic for very long at all. And in fact, they developed it while they were on the antipsychotic, but then it got a lot worse after they tapered and stopped it. And they didn't taper slowly, so it was done fairly quickly elsewhere. So they'd come from another country to be seen, and they're doing a ketogenic diet, but I have to say I haven't seen any noticeable improvements yet for that person, and that's been a good couple of months now. And usually when I see improvements for people, it tends to be fairly quick. That has been my experience. So within 2, 4, 6 weeks, that kind of time scale.
Okay. But those patients are still on the meds.
No, but they're on different medications now because it has evolved from akathisia that induced suicidal thoughts to more of an anxiety, mixed anxiety and depressive type symptoms. But I don't know, it's been quite a learning curve for me because I'm still really querying, is this all part of protracted withdrawal, or is this a separate, what we would call illness as anxiety or depression? And I don't think there's a clear answer on that. I suspect it's probably partly to do with protracted withdrawal. And I also suspect, I just wonder if that's why we haven't seen the same results with keto yet for that person.
Yeah, it's difficult because every time you restate the medication, it triggers the kindling effect. So it's the response from the brain that the body is different each time you restate the drug. So it's difficult. I believe it's also difficult for you as a doctor to figure out what's the real cause. Is the meds, the protracted withdrawal, or something else? So it's I assume it might be devastating.
Yeah, I was just going to say, I don't think there's great recognition amongst clinicians about protracted withdrawal still, even though there's lots of information out there now. And, maybe I'll do some teaching for the team that I work with locally, but I think, I don't know why, I think there's still a general resistance to look into that subject. And, we could guess what the reasons might be, but it's maybe not for me to comment.
Yeah, first you need to resolve all the underlying conditions, like you mentioned, insulin resistance, because with protracted withdrawal, it's also like, and this is a misnomer. The protracted withdrawal, it's more likely like neurological iatrogenic injury. But the point is, I had a client who did the perfect tapering from escitalopram, like very slowly, very like hyperbolic tapering, and he started to having protracted withdrawal year and a half or post discontinuation. So it's extremely difficult to figure out what's going on, since you are year and a half of the meds and suddenly something is changing, and you did the perfect tapering. So it's like each case, every time it's shocking that, and I believe in you have to believe in each case, and you cannot simply just guessing or suggesting that maybe it's something else. But it's difficult to figure out if it's the real if it's the protracted withdrawal or something underlying. But and how does the ketogenic diet help with this brain injury from the psychiatric medications? Like, what's your...
Yeah, so the ketogenic diet can be helpful for even if somebody's had a visible brain injury, such as a traumatic head injury, for example. There are studies showing clear benefit in terms of reducing inflammation, improving the energy supply to the brain, and reversing insulin resistance that may be there. It's often hard to know what's the best way to explain to people. I think it always comes down to oxidative stress, which is when you have an imbalance between antioxidants and pro-oxidants in the brain. It comes down to inflammation. So there's so much science out there about the detrimental impact inflammation has on the brain and the central nervous system. It also comes down to slight alterations in, well, maybe not even slight, neurotransmitter pathways, but it's not the serotonin pathway that I'm talking about. It's more glutamate and GABA. So yeah, I find it all really fascinating because a ketogenic diet can cover all bases in terms of targeting underlying inflammation, turning off certain pathways that are pro-inflammatory in the body, helping even the immune cells within the brain to express an anti-inflammatory form instead of being activated in a pro-inflammatory form. And they provide more energy per unit than glucose does, so they're a more efficient fuel source for the brain. And there's just many, many positive benefits to ketones.
Yeah, so the way I see ketogenic diet is like the baseline for healing. Like you need to be in ketosis for to help your body regenerate from this, because we can call it like autonomic dysregulation, right? After taking psychiatric medication, so you need to be in ketosis to start recovering, to have this autophagy increase and all this machinery going on. But the difficult part is also the keto flu. I don't know, if you have experienced the ketogenic flu in the adaptation phase, but
not that I remember. Although I do remember when I used to go to the gym in the early days, not having much energy. So that was probably when I was keto adapting. But I have to say, quite a number of years down the line now, that's no energy at all. That's no issue at all in terms of energy and endurance and sports performance. If you're into that kind of
because
thing.
you're running out of glycogen, right?
Yeah.
So
Yeah.
crashing, but it's extremely difficult, because I also recommend to going into ketosis or like pure carnivore even, because it's also very beneficial. But the keto flu, especially when you are in protracted withdrawal, it's devastating, because and especially when you are addicted to carbohydrates or like processed food, because you need to crave. We have this food cravings and all this stuff since when you in this adaptation phase. But yeah, and did you have any patients with PSSD, like post-SSRI sexual dysfunctions, and how did they resolve this condition, or how did you help them regarding this?
Yeah, so I have a couple, although I haven't seen them for a while in terms of my private work. Within more mainstream work, it's tended to be people on medications at the time and then experiencing sexual side effects whilst on an antidepressant. Unfortunately, the small number of people that I've seen privately, I haven't seen them recently enough to know what their results have been. So I haven't seen anything that's been incredibly successful so far. But the specific people I'm thinking of are in quite difficult situations, so I don't know that they're fully implementing everything. In fact, I know that they're not, from the sort of communication I've had from them. But yeah, I'd be very interested in your take on that and experience.
Yeah, I mean, resolving PSSD from my perspective and from my observation is like sexual dysfunctions. They are returning as a last part of protracted withdrawal. First goes
Right.
cognitive functions, then emotional functions, and then lastly sexuality. Because like from the evolutionary perspective, your brain restores things that they are crucial for your survival, and sexuality is not so important when you can like you don't have any cognition and intellectual functions. So it's a long process, but ketogenic diet and stimulating neuroplasticity, increasing brain derived neurotropic factor by heavy weightlifting workouts. It's also like it's like, since we don't have any treatment and the etiology is still unknown, this is the best we can do to survive this, and it will resolve over time, but it takes a lot of time, and unfortunately. Yeah,
Have you ever used red light therapy or anything like that?
I
For
I use sunlight.
Okay.
Yeah, I didn't, I haven't, but like, do you have any experience and some positive results with red light therapy?
Yes, but not specifically for PSSD. But I just wonder, and I should have read it before we talked today, but I remember reading something in the research literature and thinking that could be a possible mechanism that might help. But I don't have anyone that I've tried it on, or they've tried it on themselves, to be able to know if it would be helpful in that situation. But certainly from a mitochondrial health point of view, it can be helpful.
Well, it can't do any harm, I believe. So it's worth to give it a shot. But yeah, there's like there are pelvic floor therapy, there's like one theory regarding small fiber neuropathy, so then you can go with this immunoglobulins, but it's like, it's so-called bro science, because we don't have any research going. There's one guy, Malkegani, who's running some research, but I believe the approach is basically to stay off the meds and help your body to heal, like with sun exposure, diet changes, and all this, let's say, healthy lifestyle. You cannot get prescription to go do the jogging. But it's funny because there was one study comparing like running therapy versus antidepressants, like classic antidepressant therapy, and the outcome was like the results were way better in this group of people who were doing just simply cardiovascular exercises. So it's
Mhm.
like, but
Yeah, and I guess we've known for years that antidepressants are overprescribed, and also the evidence has been there. I think the literature tends to talk more about mild depression, but it's difficult the way the health services are set up, as in very short appointments and prescriptions being given out quite quickly. But it's just a shame if people end up not seeing the success that they would want to see taking antidepressants, and when they could actually have something fairly simple that might well improve their health overall.
yeah, and it's like, you know uh, it's like medicating normal. Like, you do experience in your life grief, anxiety, sadness. It's like it's part of being a human, and you have to deal with it like one way or another. I know it's devastating to lose a parent, to lose a job, and all this stuff, but instantly being prescribed antidepressants to ease the pain, it's like,
Yeah, I agree. Yeah, we talk a lot, well, certainly within the team that I work in, about not over medicalizing things, but I know there's a lot of variation and variability between different practitioners
and is
and
it
as to their
changing in
tendency to do
UK?
that.
Like, is it changing the mindset, the paradigm? Is it changing, like, or is it still like over?
Yeah, I don't know if it's changing, because usually it's not unusual for me to see people coming through the service who've been started on antidepressants in primary care, so by their GP, or have tried multiple different antidepressants over the years, only for us to think that it's not really depression that's going on, it's a different problem, and that's why maybe they haven't noticed any benefit from the medication trials so far. Other people might have other perspectives on that. Um, but yeah, I'm not sure that that's changing,
Okay.
or if it's just what we're talking about in my specific team. I don't know.
Yeah, so it's gonna be a long process, I guess. But
Yeah.
yeah, with here in Poland, like, we still have this, chemical imbalance theory running.
Oh, I know.
Is
Same.
it still valid in UK, or you don't do this anymore to your patients? Like, you don't say that you have this imbalance in your brain, you need to adjust it with some fluoxetine or whatever.
Oh, I don't say that to patients,
I
but
I I know you don't, but
I can't speak for all of my colleagues. I have seen people, probably more in my private work, who come through and they say, I was told I had a chemical imbalance, and why isn't the antidepressant working? So yeah, I think it's still out there.
yeah, it's like, we're 20 years behind the US, and it's changing. When I spoke with Robert Whittaker, he told that all in European countries, they are still like, I know UK is not in Europe anymore, but the
Mm.
point is that it's a long way to go to change this paradigm. And but you're doing a great job that you stand aside from this mainstream approach. Even though you're still prescribing the meds, but you're aware of the consequences. So that's a huge
Mhm.
difference than to just blindly prescribe them and believing. And do you think that they are like not aware what these drugs are capable of doing, like in the long term, or they are just like, cynical about it, or like the other doctors, like?
I mean, I know some psychiatrists who think people should be on antidepressants long term. Um, I personally always tell people about PSSD if we're talking about prescribing an antidepressant. And usually, to be honest, it's somebody asking me for an antidepressant rather than me saying, let's do that first line. Yeah, I don't know. Like I said, I just think the knowledge isn't all that great, and there can be different reasons for why that is. But I think there's been quite a lot of resistance to recognize adverse outcomes particularly if people take higher doses for longer periods of time. So I think there's a lot of learning still to come. And like I said, I don't feel like I'm an expert in protracted withdrawal, but I think it's certainly a conversation that we should all be having and
Yes.
being mindful of.
Yeah, it's a new thing, let's say, because right now we still do gaslight patients when they come back
Mm.
with withdrawals, and it's recurring depression or something else. But it's gonna take some time to to be aware, because there is this medication spellbinding when the patient is unaware of the symptoms they have, and it's difficult to convince them that you might have protracted withdrawal and it's not something else, since you are 1 year off the meds and your brain is then and your brain is just starting to rebalance and go back to homeostasis.
Yeah.
But yeah, it's a difficult territory to mm, um, yeah. So and in UK, your prescriptions rate are decreasing or increasing recently, like of the medications people are still being over medicated, or is it the tendency that it's going down, or how it
I haven't noticed it going down. I suppose in my own practice, I think it has, but that's because we're doing a different approach. But I think just generally, I still see people coming through the service on multiple medications and people who've been on them for a long, long time. And, I don't know, it is what it is, I think, because there's always going to be variation in prescribing practices. So it's a bit hard to make generalizations, but I can't say that I've noticed a particular reduction in prescribing from
yeah.
what I've seen.
Yeah, it's funny because when antidepressants showed up on the market, they were supposed to be prescribed no longer than 6 months. This was the issue, and somehow it has changed, and there are like lifetimers on those drugs, and like when in the 70s, when you read the leaflet from let's say Prozac, whatever, the implications for the medicinal practitioner was to prescribe it no longer than 6 months, and now no everyone forget it about it.
I think even official guidelines talk about 2 or maybe 3 years maximum, but again, I don't see that necessarily reflected in practice. It's just coming to mind. I've forgotten some of these people, but over the years, I've seen a few older ladies who were on paroxetine for 20 odd years who, after stopping it, then ended up coming to the attention of psychiatric services and relapse. Well, here I go again, relapsing, but becoming unwell in quite a significant way, and having great difficulties regaining their function again to
Of course.
before that happened. And yeah, reintroducing paroxetine in that small number of cases that I can think of didn't solve the issue.
And did you notice that the long-term users of antidepressants, when they discontinue the medications, were simply fine? Like the let's say acute withdrawal resolved, and they were just simply okay, or you didn't follow up them like for a year or 2 years after quitting the antidepressants, because it's
Yeah, I won't have seen those people just because of the part of the service I work in. So I work in a crisis team,
oh,
and so we see people at their worst point in time.
okay.
So
So you could follow
um,
up with them, yeah.
yeah, and to be honest, most psychiatrists, well, where I am anyway, it would probably be the GPs that might see that, because if people are doing well, they tend to be discharged from follow-up, so they won't be seen and followed up by a psychiatrist.
Yeah, this is the huge issue, because you see, okay, he's fine, he's stable, but when you follow up them, it's then something else is going on in their life. So you have your book about your metabolic. What's the title? I forgot. Metabolic.
Metabolic madness.
Madness. Yeah.
Yeah.
Metabolic madness. And what specific diet do you recommend for your patients? Like, is it pure ketogenic diet, or is something more extreme like carnivore diet or elimination diet, or like?
Yeah, I mean, I recommend both. So if somebody's really dealing with an autoimmune disorder and particularly inflammatory bowel disease, I would probably veer more towards carnivore for those people. It's been variable though in terms of the clients I'm working with who's already doing carnivore or who's open to even considering carnivore, but like ketogenic is where I would generally navigate with people, just because I think low carb can be great and not everybody needs to be ketogenic. So some people can get away with doing more of a paleo type approach, or seasonal eating is another aspect. However, just purely in terms of the anti-inflammatory benefits, I would prefer if people were ketogenic, at least for a period of time, to promote healing.
And how do you find carnivore superior to ketogenic diet? Because it's the extreme version, let's say. I've done it for like few weeks, but I couldn't make it any longer. And
Oh, really?
it was, I had some temptations.
Okay. It can be superior in my experience. So I know quite a number of people where keto wasn't enough for them, but I know people who've managed to resolve decades of severe depression, anxiety, and psychosis using carnivore.
Both the diets, you're, in both way, you are in ketosis. So how carnivore diet is superior than ketogenic with like no more than 50 grams of carbohydrates per day?
I mean, I sometimes think it has something to do with nutrient density. So, and how much red meat in particular that people are eating, because there are so many beneficial compounds, shall we say, within red meat that reduce oxidative stress at the level of the neurons in the brain. Also, for certain client groups like autism, I'm thinking of, there can be carnitine deficiency, which is a major issue, and then red meat would be higher in that. And I think for some people, there are irritants or anti-nutrients within non-animal based foods that can then cause gut issues and not necessarily dysbiosis, although it could be leaky gut, those kind of issues.
So the best approach is to like elimination diet. If something doesn't suit your guts, just leave it alone. And
yeah, I mean, dairy can be problematic for certain people in terms of provoking an immune system response that can then influence inflammation in the brain via the gut-brain axis, and there can be all sorts of nuances involved, just depending on the specific individual.
Yeah, especially since the antidepressants are triggering the destroying microbiome so severely.
Well, they act as antibacterials, don't they? And that's I don't know how correct I am about this, but I often think, and this is my view, that people who gain benefit from the drugs, maybe they had some sort of dysbiosis to begin with, that the antidepressant impacts on the microbiome in some sort of.
It is interesting. Yeah, they have like shitty diet, and then they start taking the drug. They're changing their biome, and they have this positive response. Yeah,
maybe that's the main mechanism that I could possibly think of. But yeah, I mean, it can cause gut issues.
And in withdrawal, when they are in protracted withdrawal, or the probiotics sometimes do the job. Like they're highly beneficial for patients with. I did it on myself. I started experimenting with different probiotics. I forgot the name of the specific strain of probiotic, but it helped me tremendously. And meat itself, like the grass-fed beef, is the best way to go, and eggs. And
yeah,
but sometimes when I'm like with my friends and they order pizza, sometimes it's but it's like I'm staying in the keto. And you're on the ketogenic diet as well, right? Or
yes, carnivore. I do.
You're carnivore, okay? For how many?
How many years? Yeah, 5. It's been over 5 years now. So.
And only grass-fed beef, or
mostly, not exclusively, but mostly. But I'm not lion diet, so I'll have other things like eggs, and I eat some pork. That would only be free range, like local farm type stuff. But yeah, mostly beef or lamb, eggs, and I think DHA, so omega-3s are really important for brain health. So like salmon roe or including some sort of fatty fish can be good, as long as they're not farmed fish.
And what about electrolytes, vitamin C? Like, do you supplement, or do you like eat? I forgot.
Liver, organ meat. Yeah. I'm not a massive fan of organ meats, I have to say. So I don't eat them routinely. Although I could eat pate if I wanted to. I can stomach that, but I supplement with a small amount of vitamin C, but I don't use large amounts because I don't think you really need large amounts if you're on a low carb ketogenic diet.
Yeah, this is the only vitamin. And what about the electrolytes like magnesium and all this?
Yeah, so I take magnesium routinely, and I usually suggest to people that they consider doing that just because it's so deficient within the food chain and it's so important for brain health as well.
I
Well,
read a study where like the 70% of population is in magnesium deficiency.
yeah,
So,
yeah.
so yeah.
And what else? Yeah, minerals are really important when you're ketogenic just because you have a diuresis and you can become a bit depleted in minerals if you don't make sure your salt intake is okay. And I think we've been given a lot of incorrect information about salt over the years. So
Of course.
once you go down this rabbit hole, there's a whole re-education that you have to do for yourself. And actually, obviously, people need to make sure they feel comfortable and do their own research on all of this. But I think there's a lot of good information out there now to support ketogenic and carnivore approaches, including salt for minerals.
Salt intake is highly underrated. Yeah,
Yes,
yeah, yeah.
agreed.
That's for sure. Like, but I remember when I was in this carnivore diet, I was all the time in caloric deficit. It was because I was waking up in the middle of the night, and I couldn't, eat enough because I felt full. But on the other hand, I was still in caloric deficit. But maybe I will give it another shot because. And just out of curiosity.
Yeah.
Yeah,
I think it's interesting when people go carnivore because I think in my experience, it can take a bit of time to be able to eat enough meat because I remember in the beginning, and lots of people find this, it's so satiating and you're not used to eating that amount that it can take sometimes months to really build up a tolerance
yes.
and adjust your own set point really in terms of satiety and homeostasis, I guess we're talking about again.
Yes, it's I couldn't honestly I couldn't make it. At some point I started adding eggs, then I added avocado, like all the it's still ketogenic, but I couldn't handle like the meat itself. It was too boring for me. But maybe maybe I will give it another shot. But there is this guy Sean Baker. I yeah, he's like
Yeah.
15 years in carnivore diet. He built muscle mass, so it's like it's doable.
Oh,
But
for sure.
yeah, yeah.
Yeah, it's an interesting journey because I think your taste preferences change over time as well.
Of course, and the
Mm.
strawberry tastes like candy, and yeah, it's like your
Yeah,
response to sugar. It's
yeah,
total.
because a lot of people just can't get their heads around a carnivore lifestyle because they say, "Don't you miss certain foods?" And I just say, "No, actually, I don't think about it." And
Yeah,
yeah, for me, it's brought a whole new personal food freedom that
yeah.
because I had problems with sort of carbohydrate addiction for
Oh,
many,
who
many,
doesn't?
many years. Mhm.
Who doesn't? I
No,
mean,
I know. Well, lots of
yeah,
people won't admit it to
yeah,
themselves.
like overeating if you have feel sad or you need some extra
Yeah.
dopamine boost. Yeah, I
Well, that's what's really interesting because for years I thought I was an emotional eater, but when I went carnivore, I realized I wasn't. It was actually a carbohydrate
and
addiction.
it's pure addiction, and it's like
Yeah,
processed carbohydrate addiction. It's nothing
yeah.
else. Yeah, exactly. People are not aware, and they are like defending it like a drug addicts. Like I remember,
Oh, I know.
yeah, when I tried to introduce my girlfriend to ketogenic diet, and she was so pissed off that oh, how can I live without eating this cupcake or whatever.
Oh,
Like, but
yeah, yeah.
and when she, because there is like very low ketonic diet protocol of LCKD, like when you intake 600 calories per day for 6 days, and it triggers the ketosis way faster, and then you go follow up with the regular ketosis. And we did this, and I remember like I was irritated, but she was totally like craving this junk food basically. So
Yeah.
and
No, people are protective of their comfort foods, I guess.
yes, yes, but it triggers discomfort. It's like comfort
Mm,
for 5 minutes of this dopamine rush, but it's not worth it. And
so true. Yeah.
in psychiatry, it's like it's a game changer, but people tend to. And it's funny because when you are on antidepressants, you tolerate junk food totally. Like you can eat. I could eat when I was high on sertraline, and my microbiome was numbed, or I don't know what was going on in my microbiome when I was on those drugs. But I could eat whatever I want, and I was feeling fine all the time, 24/7.
Interesting.
I didn't have any crashes from food, nothing. And right now, when I'm like sober for 6 years, and I do sometimes, I don't know, eat some junk food, let's say, occasionally, I do crash for like 3 days. It takes me 3 days to resolve this. And it's like it's worth. It's there is no way that I can continue to eat junk food because it's pointless. And
Mhm.
I agree that there is like high correlation between eating junk food and antidepressants intake. So
Mhm.
yeah.
Yeah, yeah, and yeah, there's quite clear research out there showing a lot of it's based on sugary drinks and in younger people, so teens, for example, but just increased rates of anxiety and depression the higher your intake of sugar,
Or
essentially.
ADHD, then they are
Yeah,
still.
oh, that too, yeah,
Yeah.
definitely.
Now in Poland, there is like everyone is diagnosed with ADHD, and
Same
there
here, yeah.
were antidepressant. Now we have this methylphenidate, so it's like the business is running. But if you resolve this gut issues, the diet issues, the health, the physical activity, it does calm down the nervous system. So we won't need any amphetamines to your to ADHD. So
Interesting, yeah.
it's funny how it is. It's a tragedy on the one hand, but on the other, like how can they don't see this? Like I'm still wondering if they don't see this on purpose, like, or is it like they are just because when you are in this bubble, in this niche, and you graduated, because I was studying neurobiology, and I was also on the medical faculty, and they, when you are in some kind of niche, you have some specific mindset, and it's difficult to open up to some different ideas. And
Oh, for sure.
that's why it's so impressed that you overcome this and you see the other side of this of this puzzle, that it's not only prescribing drugs and gaslighting people, that
Yeah.
yeah, but you do this sometimes. I from what I observed, that the doctors do this involuntarily. They just they that's how they were educated regarding some
Mhm.
underlying condition. And they say, okay, I learned about it like 20 years ago, and I will just simply repeat it. That it's is this or is that, but they don't see the bigger picture. And
Mhm.
the patients do need more doctors like, yeah, like you, like Joseph with Turing, like a few others like this,
Mhm.
like
Yeah, when you were talking there, it just came to mind somebody I saw recently who had a big relapse in bipolar disorder after they came off a ketogenic diet, and they got better again once they implemented keto, and it took about a month. But what was really interesting was that at the same time, they had a massive flare in their inflammatory bowel disease, so their Crohn's disease. And I know from that person that they tried discussing it with their GI specialist, and there are other psychiatrists that they see. So I knew this person from the metabolic clinic, but they have another psychiatrist who prescribes for them. And I know that they were told that their gut health has nothing to do with their mental health. But I saw them a few weeks later, well, a few weeks ago, a couple of months after getting better, and their their blood test measuring inflammation in the bowel, so a calprotectin level, it was so high when they were unwell from a psychiatric perspective that the GI specialists were talking about admitting them for immunotherapy for their Crohn's disease. But actually, after doing keto and not taking any other medications, this person's calprotectin levels back to normal range again. So they were on the verge of going into hospital, and and we had a conversation, and I just said it was really nice actually just to see in black and white like what we were saying all along, because I remember her asking me when she was very unwell, my gut's in a terrible state. So has this got something to do with my mental health just now? And I was saying to her, yes, in my opinion, it does. So let's see what we can do about it.
so yeah, it's a great satisfaction, yeah, to resolve something that somebody else was just simply gaslighting. Yeah, it's you're doing a great job for, yeah, for others, and it's a safe approach. This is the most important one. You do not harm. This is the first,
Yeah.
first amendment. Do not harm, and people were like,
Yeah, I think, I've got an interest in medical ethics as well, and I don't think we do a very good job of informed consent. But that's not just psychiatry. That's generally. I mean, we won't get too political, but the last number of years have shown that as well. So, yeah.
yeah, yeah. So thank you for joining this podcast, Rachel. It was like pleasure to meet you, and to spread awareness. That I will link your website under this YouTube video, and let others know that you are able to help with your holistic approach if somebody needs
Thank you.
help with their symptoms, or either if it's protracted withdrawal or tapering, so it's good to get someone like you. Uh, so
Thank you. No, thanks for having me. It's been really
yeah,
interesting conversation.
yeah.